In this lecture, I'm going to talk about neurocutaneous syndromes. Neurocutaneous syndromes are sometimes difficult because there's a lot of different skin lesions and a lot of CNS or neurogenic lesions, and it becomes difficult to keep track of things. So it can get to be very complex. So there's only 5 lesions, 5 neurocutaneous syndromes that you need to know, and those are neurofibromatosis 1, neurofibromatosis 2, tuberous sclerosis, Sturge Weber, and von Hippel-Lindau. And you should be able to identify the disease if you're given the tumor or the skin lesion, and you should be able to predict the screening test given the disease. And you should be able to state some basic facts as well. So I'm going to try to make this as simple as I can, but it's sometimes it can be very difficult. I encourage you as much as possible to rewind the lecture as needed, and to pause and to slowly try to absorb the lecture. So with that, the first tumor that I'm going to talk about is an angiomyolipoma of the kidney. It's basically a fat-containing tumor, and that's highly associated with tuberous sclerosis. You can see AMLs in patients who don't have tuberous sclerosis, but if you have a skin lesion and you have an angiomyolipoma or AML, think tuberous sclerosis. Bilateral schwannomas, they're very specific for neurofibromatosis 2. Schwannomas arise from cranial nerve 8, and they're at the the stem could be a cerebellopontine angle mass. Excuse the spelling over here. And then another thing is optic gliomas. Optic gliomas are pretty specific for neurofibromatosis 1. So if you see a question stem describing a patient with various skin findings or other findings, and then they have a tumor encasing the optic nerve, it's an optic nerve glioma, that's neurofibromatosis 1. Hemangioblastomas are very specific for von Hippel-Lindau, and so it's basically a brain or spine or retinal cyst with mural nodule, enhancing mural nodule. That's a hemangioblastoma, very specific for von Hippel-Lindau. Subependymal giant cell astrocytoma, also abbreviated as SAGA, is a tumor located in the ventricles or the CSF foramen, such as Luschka or Monroe, highly specific for tuberous sclerosis, and it's also one of the major morbidities of tuberous sclerosis. Rhabdomyoma, intracardiac muscular masses or intraventricular masses, specific for tuberous sclerosis. Leptomeningeal angiomatosis, specific for Sturge Weber. Renal cell carcinoma, seen very commonly in von Hippel-Lindau, one of the major sources of mortality. Lymphangiomyomatosis, also known as LAM in adult women, tuberous sclerosis as well. CNS tubers, this is easy, tuberous sclerosis. Pheochromocytoma, it's seen in von Hippel-Lindau. Okay, so I'm just gonna, Okay, and then as far as the skin findings go, cafe au lait macules, these are flat hyperpigmented lesions, they're seen in NF1. Neurofibromas, which are soft skin-colored bumps, are seen in NF1 as well. Ash leaf spot, these are flat hypopigmented, not hyper, but hypopigmented lesions. They're seen in tuberous sclerosis. Port wine stain on unilateral eyelid and forehead, Sturge Weber. Leach nodules on iris, or any really sort of nodules, and the answer choices are nodules on the iris, and the answer choices are the various neurocutaneous syndrome, pick NF1. Facial angiofibromas, tuberous sclerosis. Axillary freckling, NF1. And that's it. Okay, and then so required screening. So NF1, the big source of morbidity here is, there's a lot of morbidity in NF1, but optic gliomas are huge in NF1, so you want an eye exam to screen for those. The interval follow-up is not important. It's because it changes and it's complex, but just know the exams. NF2, the big source of morbidity is vestibular schwannomas, can lead to hearing loss, and just having a mass near the brainstem is bad, so a brain MRI. Von Hippel-Lindau, so the important lesions are a hemangioblastoma, so CNS MRI, so brain and spine MRI, as well as screening for renal cell carcinoma, which is another source of morbidity for von Hippel-Lindau. So, by the way, hemangioblastomas are benign tumors, but again, the mass effect leads to a lot of morbidity. Abdominal MRI for renal cell carcinoma, and I want to emphasize it's clear cell renal cell carcinoma, it's not papillary or chromophobe. Plus metanephrines, either serum or urine metanephrines for pheochromocytoma screening, and then eye exam for retinal hemangioblastomas. Sturge Weber, highly associated with glaucoma. Glaucoma screening or eye exam. Tuberous sclerosis, you want to do brain MRIs to look for SAGA, which is subependymal giant cell astrocytomas. And then abdominal MRI to look for AML. AMLs are fatty tumors of the kidneys, as I mentioned. The problem is that they can bleed. They can lead to significant retroperitoneal hemorrhage. Especially if they get to be a certain size. So that's also indicated for that as well. So just looking at these pretty much, you can tell, I would pause over here and just look and see, and this sort of illustrates what are the most important tumors for these 5 neurocutaneous syndromes. And then as far as important facts, almost all of them are autosomal dominant except Sturge Weber. Most of them are associated with some sort of intellectual or learning disability or developmental delay. Stroke and glaucoma is common in Sturge Weber. NF1 chromosome 17, NF2 chromosome 22, 2, 2, 2. And 1 is less than 2, so 17. So remember 17 and 23. Tuberous sclerosis, so von Hippel-Lindau is chromosome 13, so chromosome 3, sorry. And that's it. And then, you can just go back and review the lecture and pause it. If you were struggling with Step 2 CK studying and want to discuss strategy, email me at this following email. I also have a 500 question free knowledge builder quiz in the description below, or you can just click on it if that link is not active. And any comments appreciated. Thank you.